Welcome to Global Lab Academy. Here we introduce medical laboratory science in a simple yet professional way for people all around the world. From basic principles to specialized tests, each video is an opportunity for precise and practical learning. Our mission is to enhance both public and professional knowledge in laboratory medicine, where science, health, and the future are interconnected. Join us, and let's bring the laboratory from behind the scenes into everyday life. What is CRP? Yes. CRP stands for C-reactive protein, a substance produced by the liver in response to inflammation. It's part of the body's acute phase response, meaning its levels rise rapidly when there's tissue injury, infection, or immune activation. These terms are used interchangeably in clinical and laboratory settings. When you see CRP on a lab report, it refers to the concentration of this protein in the blood. Why is CRP important? CRP is a nonspecific marker of inflammation. That means it doesn't tell you exactly what's causing the inflammation, but it does indicate that something is wrong. Elevated CRP levels can be seen in bacterial infections, e.g. pneumonia, sepsis, autoimmune diseases, e.g. rheumatoid arthritis, lupus, tissue damage, e.g. trauma, surgery, chronic conditions, e.g. cardiovascular disease. In clinical practice, CRP is often used to monitor disease activity, assess response to treatment, differentiate between bacterial and viral infections. CRP tends to be higher in bacterial cases. For CRP testing, the required specimen is serum, the clear fluid that remains after blood has clotted and been centrifuged. This is standard for most protein-based assays. Why serum? Serum is free of clotting factors, making it ideal for measuring soluble proteins like CRP without interference from fibrinogen or other plasma components. Specimen collection conditions. Fasting not required CRP levels are not significantly affected by food intake, so patients do not need to fast before sample collection. This makes CRP testing convenient in both emergency and outpatient settings. Immediate centrifugation and separation. After blood is drawn, it should be centrifuged promptly to separate serum from cells. Delays can lead to cellular degradation, which may release intracellular contents and falsely alter CRP levels. Collection notes, record age, and sex. These demographic details are important because CRP reference ranges can vary slightly with age and sex. For example, elderly individuals may have mildly elevated baseline CRP. Avoid hemolysis and lipemia. Hemolysis, rupture of red blood cells, and lipemia, high fat content in serum, can interfere with spectrophotometric or immunoturbidimetric assays, leading to inaccurate results. Preferred. No significant hemolysis. Even mild hemolysis can cause optical interference in automated analyzers. Labs should reject or recollect samples with visible hemolysis when possible. Why storage matters. Once a serum sample is collected for CRP testing, how it's stored can significantly impact the stability of the analyte. In this case, C-reactive protein. Improper storage can lead to protein degradation or bacterial contamination, both of which may distort test results. Room temperature storage, stable for up to 72 hours. This means that if the sample is kept at ambient temperature, typically 20 to 25 degrees Celsius, CRP levels remain reliable and unchanged for up to 3 days. This is useful in outpatient or field settings where refrigeration may not be immediately available. Teaching point. Always document the time of collection, if room temperature storage is used, to ensure the 72-hour window is not exceeded. Refrigerated storage. At 4 degrees Celsius, stable for up to 14 days. Refrigeration slows down enzymatic activity and bacterial growth, preserving the integrity of CRP for up to 2 weeks. This is the preferred method in most clinical labs, especially when batch testing is planned, transport to a reference lab is delayed. Retesting may be required. Best practice. Store samples in sealed, labeled tubes to avoid evaporation and contamination. Avoid repeated freeze-thaw cycles which can denature proteins. CRP in clinical practice. 1. Detect systemic inflammatory processes. CRP is a highly sensitive marker for systemic inflammation. When the body experiences tissue injury, autoimmune activation, acute or chronic inflammatory conditions, the liver rapidly increases CRP production. This makes CRP a valuable tool for detecting ongoing inflammatory activity, even when symptoms are subtle or nonspecific. Example: in conditions like rheumatoid arthritis or inflammatory bowel disease, CRP levels often correlate with disease activity. 2. Detect infections and monitor. Antibiotic response. CRP is especially useful in bacterial infections, where levels can rise dramatically, often greater than 100 milligrams per liter. Initial diagnosis. Elevated CRP supports the presence of infection, especially when combined with clinical signs: fever, leukocytosis. Therapeutic monitoring. Serial CRP measurements help assess response to antibiotics. A declining CRP trend suggests effective treatment, while persistently high levels may indicate antibiotic resistance, complications, e.g., abscess formation, incorrect diagnosis. Example: in pneumonia, CRP levels typically fall within 48 to 72 hours of effective antibiotic therapy. 3. Differentiate active versus inactive inflammatory disease. In patients with chronic inflammatory conditions who also have concurrent infections, CRP helps distinguish between active inflammation, e.g., a flare of autoimmune disease, inactive disease with superimposed infection. This is crucial because symptoms like fever or fatigue can overlap. CRP, along with other markers, e.g., ABS-89 ESR, procalcitonin, helps guide clinical decision-making. Example: in a patient with lupus and suspected urinary tract infection, a spike in CRP may point toward infection rather than a lupus flare. Normal reference values greater than or equal to 0.8 milligrams per deciliter or less than or equal to 8 milligrams per liter. These values represent the upper limit of normal in healthy individuals. CRP levels: less than 1 milligram per liter. Low risk of inflammation, 1 to 3 milligrams per liter. Mild elevation, possible low-grade inflammation, greater than 10 milligrams per liter. Suggests acute inflammation or infection. Note: always interpret CRP values in context. Age, sex, comorbidities, and clinical presentation matter. CRP elevation reflects the presence of acute phase inflammation, but the underlying causes can be diverse. Let's categorize and explain each group. 1. Non-infectious acute inflammatory conditions. These are immune-mediated or idiopathic disorders where inflammation occurs without infection. Arthritis, especially rheumatoid arthritis, where synovial inflammation drives CRP up. Acute rheumatic fever, post-streptococcal autoimmune reaction. CRP helps monitor systemic involvement. Reiter's syndrome, reactive arthritis. Triggered by infection, but inflammation persists independently. Crohn's disease, chronic intestinal inflammation. CRP correlates with disease activity and flare-ups. Clinical tip: in autoimmune diseases, CRP is often used alongside ESR to assess inflammatory burden. 2. Vascular and connective tissue diseases. These involve immune-mediated damage to blood vessels and connective tissues. Vasculitis, inflammation of vessel walls. CRP helps detect systemic involvement. Systemic lupus erythematosus, SLE. Interestingly, CRP may be normal during flares unless infection is present, making it useful for distinguishing lupus activity from superimposed infection. Teaching point: CRP is more reliable in vasculitis than in SLE due to differences in cytokine profiles. IL-6 versus interferon alpha. 3. Tissue damage or infarction. CRP rises in response to necrosis and cellular injury, even without infection. Acute myocardial infarction, MI. CRP peaks within 48 hours post-infarct. Higher levels may predict worse outcomes. Pulmonary infarction, often secondary to embolism. CRP supports diagnosis when imaging is inconclusive. Transplant rejection. CRP may rise during acute rejection episodes, reflecting immune-mediated tissue injury. Soft tissue injury. Trauma, surgery, or burns can trigger CRP elevation due to cytokine release. Note: CRP is not specific for ischemia. It reflects inflammatory response to injury, not the cause. 4. Bacterial infections. CRP is especially sensitive to bacterial pathogens, often rising dramatically greater than 100 milligrams per liter. Post-surgical wound infection, urinary tract infection UTI, pyelonephritis, kidney infection, CRP helps differentiate from lower UTI. Tuberculosis, chronic infection, CRP may be moderately elevated. Meningitis, CRP helps distinguish bacterial from viral causes. Bacterial equals higher CRP. Clinical Pearl, CRP is less elevated in viral infections, making it a useful discriminator in febrile patients. 5. Malignancy. Certain cancers can cause perineoplastic inflammation, leading to CRP elevation. Especially in lymphomas, solid tumors with necrosis, or advanced metastatic disease. CRP may correlate with tumor burden or treatment response. Example: in colorectal cancer, elevated CRP is associated with poor prognosis and systemic inflammation. CRP is a reliable marker, but like all lab tests, it's subject to interference. Factors that can falsely elevate or distort results, leading to misdiagnosis or inappropriate treatment. Let's break down the key pitfalls. 1. Intrauterine device, IUD. Use, mechanism. IUDs can cause localized endometrial inflammation, which may trigger a systemic acute phase response, mildly elevating CRP. Clinical impact. This elevation is not due to infection or systemic disease, but rather a foreign body reaction. Risk. May lead to false positive interpretation, especially in gynecologic or general medical evaluations. Teaching point. Always consider IUD use when interpreting CRP in women of reproductive age. Ask about contraceptive history. 2. Serum turbidity, nephelometric interference. Nephelometry is a common method for CRP quantification based on light scattering by antigen-antibody complexes. Severe turbidity due to lipemia, hemolysis, or particulate matter can scatter light non-specifically, leading to false elevations or assay failure. Best practice? Ensure serum is clear and properly centrifuged. Reject samples with visible turbidity. Lab tip: use blank correction and quality control samples to detect turbidity-related anomalies. 3. Oral contraceptive pills, OCPs, and exogenous hormones. Estrogen-containing medications, e.g. OCPs, hormone replacement therapy, can stimulate hepatic synthesis of CRP. This is a pharmacologic effect, not a sign of disease. Clinical impact. May confound CRP interpretation in women using hormonal therapies, especially in cardiovascular or inflammatory risk assessments. Example: in epidemiologic studies, CRP levels are often adjusted for hormone use to avoid bias. CRP test methods and interpretation. Part 1. Qualitative CRP test, latex agglutination method. This method is designed to detect the presence of CRP in serum, not its exact concentration. Procedure. Overview. 1. Reagent prep. All reagents and samples must be at room temperature. Latex reagent should be gently mixed, not shaken, to preserve particle integrity. 2. Controls. Use positive and negative control sera to validate the test. Each control is placed on a separate spot on the slide. 3. Mixing. Add 1 drop of latex reagent to each spot, then mix using a wooden stick or plastic applicator. 4. Reaction. Gently rock the slide for 2 minutes to facilitate agglutination. 5. Observation. Look for visible clumping. This indicates a positive reaction. Teaching point: latex particles are coated with anti-CRP antibodies. If CRP is present, it binds and causes visible agglutination. Part 2. Semi-quantitative CRP test. This method estimates CRP concentration by serial dilution and observing the endpoint of agglutination. Procedure: 1. Dilute serum with 0.9% saline in increasing ratios, 1 to 2, 1 to 4, 1 to 8, 1 to 16, 1 to 32, 1 to 64-2. Perform a agglutination test on each dilution, following the same steps as the qualitative method. 3. Interpretation. The last dilution showing agglutination is used to calculate the CRP titer. If no agglutination is seen at any dilution, report as negative titer. Calculation to estimate CRP concentration, CRP, micrograms per milliliter, equals sensitivity times A minus A equals reciprocal of the highest dilution showing agglutination. Sensitivity equals typically 6 or 7 micrograms per milliliter, depending on the kit interpretation of results. Positive. Agglutination equals CRP present. Negative. No agglutination equals CRP absent or below detection threshold. Note, agglutination strength is not proportional to CRP concentration. Only the presence or absence matters. Limitations and pitfalls: 1. Agglutination strength not equal to CRP level. Weak reactions can occur even at high CRP concentrations. 2. Prozone phenomenon. Extremely high CRP may inhibit agglutination, causing false negatives. Always retest negatives at 1 to 10 dilution. 3. Lipemic or contaminated serum can cause false positives due to nonspecific particle interference. 4. Rheumatoid factor interference. High RF levels may cause nonspecific agglutination, mimicking CRP positivity. Best practice: always run controls and consider clinical context before interpreting borderline or unexpected results. Thank you for watching Global Lab Academy. If you found this video valuable, please click like and subscribe to our channel. And don't forget to ring the notification bell. Let this bell remind you to stay connected as we continue exploring the science of the medical laboratory together.